So welcome to the final of the KDIGO series, A Decade in the Making, Optimizing the Holistic Approach to the Evaluation and Management of CKD. Today, we're having the fifth of the 5-webinar series, Personalizing Our Approach, a focus on managing the non-diabetic patient with CKD. I want to go back and highlight our housekeeping. Microphones and cameras have been disabled. The meeting is being recorded, and you'll be able to watch it on the KDIGO YouTube channel. We will have a question and answer session after the case presentation. Please submit your questions for us to answer. If there are any technical issues, please submit queries using the Q&A feature. So today, I introduce myself. My name is Dr. Rasheeda Hall. I'm an associate professor of medicine at Duke University in Durham, North Carolina, in the United States. And I'd like to introduce Professor William Herrington in the Nuffield Department of Population Health at the University of Oxford in Oxford, UK. The learning objectives for today are listed here. Attendees will be able to understand the stepwise approach to managing patients with chronic kidney disease without diabetes and at risk of or with established cardiovascular disease. Number 2, they will recognize the risk of hyperkalemia in patients with CKD and understand how this should be managed. And number 3, they will recall the additional risk-based therapies recommended in patients with CKD to optimize management and reduce the risk of adverse outcomes. So let's get started. Before we switch to the case study, I want to show you that afterwards, we will have the panel discussion where the question and answer time will be available. So please place your questions in the chat, and we will address as many as we can. Okay, Professor Harrington.
Thank you very much, Dr. Hall. So it's a pleasure to present this case studies. There's 2 of them. I was one of the working group members on this KDIGO guideline, and it's a pleasure to share some of our discussions and decisions in terms of recommendations and practice points. So let's get started. So the first case is a lady called Hilda. You met her with Professor Michael Schlipak's discussions in the 3rd webinar. And so just as a reminder, she's 72, has had increased blood pressure for the last 15 years, and that is treated with enalapril at 40 milligrams, which is the full dose. Her blood pressure is also treated with a thiazide diuretic. And then she's had a myocardial infarction, so she's appropriately treated with a statin and low-dose aspirin. She's overweight but not obese, and her blood pressure could be better controlled. It's 140/80. Her EGFR, she's been staged, is 43, and she has a urine albumin-creatinine ratio of 150 milligrams per gram. And slightly surprisingly, she has a potassium of 5.8. I'll tell you why this is surprising later. But you've all learned now about the CKD staging, this KDIGO heat map, and this is where Hilda fits. She actually fits in the very high-risk group because she has a CKD stage G3B A2. These independently add, and you can see the A2 means she's at higher risk than someone who would have lower levels of albuminuria. Now, Hilda has got CKD. She's got hypertension, which needs to be better controlled, but she's also got a potassium of 5.8. She's on the full dose of enalapril. What would you do about this? And there's a poll which you should start answering now. Would you discontinue the RAAS inhibitor therapy? Would you discontinue the enalapril? Would you down titrate the dose, or would you continue it as is? Start your votes. Okay, I can't see many votes at the moment, but perhaps I will be able to in a minute. Okay, I think that's long enough. We can close the poll. So we had 30% down titrating the RAAS inhibitor and 70% continuing it. And I'm so glad to see that no one would discontinue it. Okay, so I'll tell you what KDIGO would recommend you do. So I think this is quite an unusual case because people without diabetes actually don't often have hyperkalemia to this level with this level of EGFR. So it's slightly unusual and you'd want to investigate it. But it's actually very important that she continues her RAAS inhibition. We have a recommendation in the guideline that people with CKD and moderately increased albuminuria, so that's A2 levels without diabetes, should be started on a RAAS inhibitor. It's level 2, so it's a suggestion. The majority of patients would want to be treated, but some would not. And the level of evidence is C. And this is perhaps because we have excellent data for the use of RAAS inhibitors in people with diabetes, particularly at A2 and A3 levels. And the trials in people without diabetes are mainly looked at highly proteinuric groups. But we know that albuminuria is an incredibly strong risk factor for progression. In fact, it's a log relationship. Now, as epidemiologists, when we see this, we suddenly identify a risk factor whose importance rapidly increases as it rises. So even an A2 level is really important. So we'd want to maintain her on the RAAS inhibitor. But what we'd actually like to do is to work out how to retain her on it. So hyperkalemia can often be managed by simple other measures to reduce potassium. And we'll talk about that in the next slide. What we would do is we would say you would want to discontinue or reduce the dose if there were particular problems. And I don't think this level of hyperkalemia is a particular problem. If it became uncontrolled, we'll talk about that on the next slide, or of course she's developed hypotension or is unwell, then we would want to reconsider this decision to continue the RAAS inhibitor. So the 70% of people that suggested continuing the RAAS inhibitor at this dose were actually aligned with the KDIGO guidelines. So how would we go about managing these potassium levels in the context of important risk modifying therapy? Well, KDIGO's got a practice point, and they suggest we implement an individualized approach in people with CKD G3 to G5 and emergent hyperkalemia, for emergent hyperkalemia, and that includes dietary and pharmacological interventions and involvement of a renal dietitian or accredited nutrition provider. And I actually think they're particularly important in this case because we've got a potassium which is slightly higher than one would expect. So there may be some explanation for this high potassium. Obviously, as a clinician, I'd review her medication. Is she taking any over-the-counter non-steroidal anti-inflammatory drugs or any other antibiotics? But I think it's quite important she gets a dietitian referral because it may be there's a dietary component, which is easily modifiable. She's already on a thiazide diuretic, but you might consider a thiazide diuretic or loop diuretic to try and reduce her potassium if she has evidence of fluid overload, or indeed if she's not one already and her blood pressure needs optimizing. Although bicarbonate levels are normally relatively preserved until late stages of CKD, there's a possibility with this lady with hyperkalemia that she may have an acidosis that needs to also be reviewed. So I'd measure bicarbonate. And occasionally in people who've got very severe hyperkalemia or moderate hyperkalemia, which is persistent, we can start to use the latest potassium exchange agents, although they're actually not likely to be needed in this case. So the last resort is to reduce or discontinue the RAAS inhibitor, or indeed the mineralocorticoid receptor antagonist. So when do nephrologists get concerned about hyperkalemia? Well, moderate to severe hyperkalemia is much more concerning for us. Moderate hyperkalemia is defined by KDIGO as between 6 and 6.4. And of course, if someone is unwell or they've got acute kidney injury, they're likely to be in hospital already. But if they're unwell and they've got this potassium, that's certainly a reason to be assessed in hospital. If their normal potassium is running in the 5s and it suddenly creeps up to 6, perhaps you'll be less concerned and you wouldn't need to admit them straight to the emergency room. An alternative would be to simply repeat it again in 24 hours. But obviously, severe hyperkalemia, we are concerned about this because it can cause increased risk of arrhythmias. Although I have to say the cardiologists are much more worried about low potassium than high potassium. But a severe hyperkalemia would, of course, require immediate action and assessment with an electrocardiogram and ECG. So helpful implementation type practice points from KDIGO. Okay, but really, as a nephrologist or as a primary care physician, because of course this patient would actually probably be managed in primary care rather than nephrology with that level of EGFR, you need to think about what you would do with this patient in terms of trying to further manage risk. You'd want to improve their blood pressure control, But would you prescribe an SGLT2 inhibitor? That's the next question. So please answer the question yes or no or unsure. Okay, just give you another 10 seconds or so on that. Okay, I think that's sufficient time. So could we close the poll? And excellent. 100% of you said yes. Okay, full marks. Okay, and this fits very nicely with KDIGO recommendations. There's 2 recommendations related to people without diabetes. Hilda, would fit into the bottom of the 2 recommendations. She's got an eGFR of 43, so she's in the 20 to 45 category. And she's got albuminuria slightly less than 200 milligrams per gram. That's a 2B recommendation. A suggestion based on B level of certainty. That's mainly because this type of patient was only studied in one of the major trials, the EMPA-KIDNEY trial, and wasn't studied in DAPA-CKD. But in EMPA-KIDNEY and DAPA-CKD, patients with higher levels of albuminuria, above 200 milligrams per gram, would have been included. So if she had a slightly more albuminuria, or indeed if she had heart failure, this would have been a 1A recommendation for use. Either way, you're all correct. So let's move on. Let's move on to case number 2. This is Leon. So Leon is another patient without diabetes. He's 64. And since about the age of 30, he's been a smoker and continues to smoke. 40, continues to smoke. He has also got coronary artery disease and raised blood pressure. Slightly younger than Hilda, though. And he is on lisinopril, actually at 10 milligram dose. That's a relatively low dose. So you can increase the dose in the UK up to 40 milligrams daily. But he's on an intensive LDL lowering with atorvastatin, a beta blocker, and aspirin. But Leon is a higher risk of cardiovascular events than Hilda by virtue of the fact that he has got a BMI of 32, a blood pressure of 157/97, and that is despite the fact his eGFR is slightly better and he doesn't have any albuminuria. So you've seen Leon's numbers. He's got an eGFR just above 50 without albuminuria. He's got poorly controlled blood pressure and his CKD and cardiovascular risk he's managing. So which one of these would you consider for Leon? The final question. Please answer as quickly as you can. Okay, let's close the poll. Okay, so most of you said you would start an SGLT2 inhibitor and up titrate the RAAS inhibition. Only 10% of you said you would start a RAAS inhibitor, and just one of you said you would start an SGLT2 inhibitor alone. Now, SGLT2 inhibitors might well be considered a panacea, but in this case, interestingly, this type of patient like Leon had not been included in the trials of type 2 diabetes, or indeed the trials of CKD. So in actual fact, we don't have evidence that SGLT2 inhibitors work in Leon. He's actually in this slightly lower risk group of an eGFR of 51 without albuminuria. So he wouldn't have even been eligible for EMPA-KIDNEY, where you could only be included in the trial if your eGFR was between 20 and 45 and you didn't have albuminuria. So he's a curious side case where Leon's risk of kidney disease progression is not sufficiently high for him to be entered into a trial. He's got CKD stage G3A, A1. So in actual fact, the emphasis here is actually on trying to make sure his RAAS inhibitor dose is maximized. So of note, Leon has poorly controlled hypertension, and we need to try and better improve that. So the practice point we have in this KDIGO guideline, because of course Leon is also the type of patient who hasn't been studied with RAAS inhibitors in the past. These are not recommendations; these are practice points. But they're to consider starting people with CKD with A1 levels of albuminuria with a RAAS inhibitor, particularly to treat specific indications like HIM, which is hypertension, or heart failure with reduced ejection fraction, and that these doses of RAAS inhibitors should be administered at the highest approved dose that is tolerated. That's because the trials that have been done have always mandated that the highest dose is used wherever they are allocated that intervention. So Leon's not on maximum tolerated ACE inhibitor. He's got poorly controlled blood pressure. He needs to have his dose of RAAS inhibitor, his lisinopril, increased. There is a nice practice point on the right here. This is quite a historical practice point, which has been reproduced in the guideline. The idea that when you initiate a RAAS inhibitor, and if you're concerned when you are changing a dose, you should within 2 to 4 weeks consider whether or not they might have a worsening of a hyperkalemia or a change in their GFR. Now, the change in GFR, small changes are expected because these drugs are purported to reduce intraglomerular hypertension. This is a sign that they are reducing some of the work of the remaining nephrons, and so that should be accepted. But large changes might represent some toxicity, particularly if it's greater than 30%. You need to review for evidence of volume depletion and whether or not they've got acute kidney injury. And also renal artery stenosis might be a consideration, and you may want to investigate that. And we've already talked about how you'd manage the hyperkalemia if that developed. You would try and find methods to mitigate against it continuing to rise, but try to retain the patient on the current dose of a RAAS inhibitor. So useful practice point. But in actual fact, what's most striking about Leon is his risk of cardiovascular disease. He's probably at least 10 times higher risk of heart failure and, in fact, separately developing a further atherosclerotic event than he is of progressing to need kidney replacement therapy in the next 5 years. His cardiovascular risk should be your main focus. He's both obese and he's a smoker. He's got hypertension. He's already got established disease. So we really need to be focusing on that in the care of Leon. And that's exactly what we recommend. So we recommend he increases physical activity. We recommend alongside the WHO recommendations on exercise to partake in moderate intensity physical activity for at least 150 minutes per week, compatible with his level of physical tolerance and his cardiovascular health. That will help reduce his body weight and his blood pressure. We also need to encourage him to have a healthier diet. He has obesity. I didn't show you it, but he's also hypercholesterolemic despite the atorvastatin. We need to encourage him to make positive changes. And KDIGO's recommendations on this include consuming more plant-based food, less ultra-processed food, maintaining a normal protein intake, but reducing sodium intake. There's beautiful cluster randomized trials in communities in the Far East, which have shown that if you supplement people with low sodium based products compared to standard sodium based products, you can reduce the risk of cardiovascular events. Clear evidence with an intervention. And then last of all, this is obvious, but poor Leon, by smoking since the age of 40, has actually doubled his risk of dying before the age of 70. It's incredibly important. He stopped smoking. It's never too late. And we could have important benefits, both on his cardiovascular risk, but also from developing respiratory disease and cancers. So the focus for Leon is cardiovascular risk prevention by lowering his blood pressure to less than 120 millimeters of mercury with ideally a RAAS inhibitor, and then trying to implement physical activity and lifestyle changes. But you can offer him, and you should offer him, intensive LDL lowering therapy. Now, he's already on atorvastatin 40, so this has already been thought of. And just as a reminder of the 2013 recommendations from KDIGO, when the SHARP trial reported that patients who've got CKD and who are adults over the age of 50 should all be treated with a statin or a statin ezetimibe combination if they're not on dialysis. And indeed, you should be considering it quite widely in people, even if they don't have CKD over the age of 50. And one of the key points we have made in this latest guideline is data since the 2013 KDIGO guideline has demonstrated it's really important in people with CKD to maximize the absolute reduction in LDL cholesterol. That's because for a given level of LDL cholesterol reduction, you actually get a slightly smaller benefit as CKD progresses. So you have to maximize that LDL difference in order to maximize the benefits. So you could consider, with Leon, adding in ezetimibe to this treatment regime. So Leon has been treated with a statin. That's excellent. It's intensive dose. It's reasonable. You could improve it. And he's also on low dose aspirin, which is also appropriate because we know he's got established coronary artery disease. So here we are. This is a nice final slide. And this is a comprehensive care for people with non-diabetic CKD and cardiovascular disease. First-line therapy is often an SGLT2 inhibitor, although there are some patients like Leon who've got eGFRs above 45 who would only be treated with an SGLT2 inhibitor from the perspective of a nephrologist if they had developed some albuminuria or if they had heart failure. We need to maintain blood pressure control for cardiovascular risk, and it would also help his risk of progression, and particularly if people got albuminuria, A2 levels or above. And then they must have their cardiovascular risk considered, a moderate to high intensity statin-based regime. And this all needs to sit on the basis, the foundation of a healthy lifestyle with physical activity of 150 minutes per day, not smoking, and a healthy diet. Now, in previous talks, we've had brilliant descriptions of the treatment of people with diabetes from Professor Ian de Boer. And there are, of course, recommendations specific to diabetes management for their complications, but in particular the use of GLP-1 receptor agonists. We haven't yet got that evidence for people without diabetes. Similarly, non-steroidal melanocortin receptor antagonists is limited for nephrological indications to people with diabetes. There's some nice advice here on which antihypertensives to use in people with diabetes. The dihydropyridines, calcium channel blockers, or a diuretic are preferred. But if you have resistant hypertension, you could trial a steroidal mineralocorticoid receptor antagonist cautiously if their potassium and their GFR are sufficiently high in terms of eGFR and low in terms of potassium. Leon was well managed with antiplatelet therapy for clinical atherosclerotic cardiovascular disease. You wouldn't use antiplatelet therapy in all patients with non-diabetic CKD. It requires people to have clinical evidence of atherosclerotic disease. You could intensify lipid lowering if there's an indication, and that would be based on local use of PCSK9 inhibitors and ezetimibe. And then it's really important, and I think I wanted to highlight the detail that's in chapter 3 of the KDIGO 2024 guideline, which covers not just delaying CKD progression, but also managing its complications. But it does cover how you would manage atrial fibrillation in people with and without CKD. And really, a core principle of the guideline is to really emphasize to yourselves and to other clinicians that we should diagnose and manage cardiovascular disease in people with CKD with the same principles that we do in other populations. There really isn't a strong reason to modify your approaches. Of course, they may change doses based on renal excretion or other factors, but really not to prejudice people's care for their cardiovascular disease just because they've got CKD. And there's also enormous amounts in other guidelines, but also this KDIGO guideline about managing anemia and bone disease, acidosis, and potassium. So I commend the chapter to you to read. Thank you.
All right. Well, thank you, Professor Herrington, for this case study and sharing the details of the practice points and the recommendations from the KDIGO guidelines. Let's get into the questions. Looks like one first question is related to the case around Leon. Can the ACC guidelines with respect to use of SGLT2 inhibitors be applied to that case?
Oh, that's very specific. I mean, a question I need to look it up. But I think the use of SGLT2 inhibitors from the randomized data in people with chronic kidney disease mainly comes from both the heart failure trials and the CKD trials. And so Leon, if he doesn't have evidence of heart failure, and he might want to look for it, given he's had a coronary artery disease, he may well have reduced or preserved ejection fraction heart failure, particularly with that level of BMI and with that also with that level of blood pressure, he may well have some evidence of disease, and that would be an indication for use because we've got very clear evidence from randomized trials to support use in people with heart failure, irrespective of ejection fraction. But from the CKD point of view, a purist would point out that he hasn't got sufficiently high risk of kidney disease progression in his lifetime. That said, SGLT2 inhibitors will one day be generic, and this may be that this will be modified by future guideline committees, but KDIGO, we were rigorous to the evidence available.
Thank you. All right, so our next question, would you recommend using potassium binders in proteinuric diabetic patients who are on the max dose of RAAS inhibitors and SGLT2 inhibitor, and they still have K that's elevated, hyperkalemia greater than 5.0.
Yeah, I mean, I think they still are really the last line therapy. Even if you really want to get people on these drugs, it's interesting, and there's a lot you can do to manage potassium before you have to give people another tablet. So we've got dietitians, you can make modifications. We've got bicarbonate modification. We can use tablets, and we can use tablets, not just diuretics, but actually, in fact, if you started someone on an SGLT2 inhibitor, you very slightly reduce their potassium on average, and you make it much less likely that they would spike. And to be honest, it's a real shame that we don't have better evidence in people who've got potassiums over 5. They were excluded from the previous trials. So the answer is we don't really know how safe it would be to start finerenone and potassium above 5. It would be a shame to have to start a potassium binder just to get someone on a drug. But if they had very high levels of proteinuria and they're progressing fast, I have to admit, I'd have my arm twisted.
Yeah, I'm with you. All right, we have another question. That is about the use of SGLT2 inhibitors in hemodialysis patients. And I'll add briefly that our guidelines really were structured around individuals who are not on dialysis yet. And so that is not included in these guidelines, but I'm sure Professor Herrington may have more to add here.
Yes. Excellent. So all of the trials in CKD continued SGLT2 inhibitors until the point they were on dialysis. And so that's actually one of the key practice points is once it's initiated, you continue it on until dialysis. This guideline doesn't touch on dialysis. I have to admit that it might be something which could be useful, particularly peritoneal dialysis, where they get a high glucose load and they have preserved renal function. But really, we have to wait for the trials. The renal life cycle trial is recruiting these types of people. And if the evidence appears, we may well start to advise even that it is safe and actually sensible to continue in dialysis patients. Nice question.
Another question in the chat, when starting SGLT2 inhibitors or MRAs, do we discontinue other therapies such as diuretics and potassium binders, et cetera?
Well, only if you really need to. The MRAs and the SGLT2 inhibitors have got the best evidence for efficacy. Now, remember, MRAs have only got evidence for efficacy in terms of renal progression in people with diabetes. This is a talk about without diabetes. In the trials that I conducted, we kept it very simple. So people without diabetes, there's very little reason to have to change anything else if you start an SGLT2 inhibitor. The effects on blood pressure are pretty modest. The effects on potassium are pretty modest. The effects on risk are large.
Thank you. Thank you. So with that, we will close out the session. Thank you for everyone who participated with the questions and were present today for this 5th and final webinar of the KDIGO series. Please tune in to the KDIGO 2024 CKD Guidelines for more information, including all the informational graphics that can be very useful for guiding your clinical practice. Have a good day. If you have a chance, please scan this QR code and complete the evaluation.